Hi guys, welcome back to the channel. So last class we have finished central giant cell tumor. Today we'll be starting with osteomas. Osteoma, clinical presentation and pathogenesis. Referred to as benign neoplasm, but they are actually hematomas that occur almost exclusively in membranous bone. बोलते तो है benign neoplasm, but they are actually hematomas. And they are mostly and exclusively seen in membranous bone. Single osteomas are very rare in jaws. Present as a slow-growing, painless, discrete bony mass that is palpable unless it is developed within the medullary space. It is slow-growing, painless, discrete bony mass. Incidental radiographic finding: round or oblong opacity. They are more common in men than women and are mainly seen in adults. Finding of a true osteoma of jaws in a child should prompt an evaluation for Gardner syndrome. Generally, in child, osteomas are not found. If we are seeing osteomas in child, we'll definitely go for the evaluation of Gardner syndrome. We'll be dealing Gardner syndrome in the next topic. On rare occasion, an osteoma will be found in tongue musculature. This represents a benign choriostoma arising from mesenchymal stem cells in the tongue. जो टंग में ऑस्टियोमा दिखते हैं, it represents choriostoma which arise from mesenchymal stem cells in the tongue. So they are not osteoma, they are choriostoma. Okay, these choriostoma, hematoma, we have dealt in starting with the terms. When we are starting odontogenic tumor, we have dealt with all these terms. Now, coming to differential diagnosis, first is tori and exostosis, but we can exclude this as it is broad-based and multiple. Now, osteoblastoma associated with deep dull pain. Ossifying fibroma is less radio-opaque compared to osteoma. And complex odontoma. In complex odontoma, we can see tooth-like structures. Okay, these are the differential diagnosis for osteoma. Now coming to diagnostic workup and treatment. They are diagnosed and treated by local excision. Mainly they are diagnosed as an incidental radiographic finding, क्योंकि routine radiographic finding में तो आ नहीं सकते. As in when we are coming with complaint, there is no complaint because it's a painless slow growing mass. तो patient को कुछ पता ही नहीं चलता है. मान लो patient किसी और चीज़ की वजह से आया and we develop osteoma. So it is the incidental radiographic finding and it is treated by local excision. Margins of more than 1 mm are unnecessary. Like only 1 mm margin is enough for the local excision of osteomas. Now coming to histopath, may consist of dense lamellar bone with little marrow. May show trabeculae of lamellar bone with a prominent fibro fatty marrow. या तो डेंस लैमेलर बोन होगा लेकिन मैरो कम होगा, या इट कैन शो ट्रैबिक्युले ऑफ लैमेलर बोन विथ प्रोमिनेंट फाइब्रोफैटी मैरो. तो फाइब्रोफैटी मैरो ज़्यादा होगा व्हेन ट्रैबिक्युले ऑफ लैमेलर बोन इज प्रेजेंट. ऑस्टियोब्लास्टिक एक्टिविटी इज वेरिएबली प्रेजेंट. सो वी कैन अप्रिशिएट ऑस्टियोब्लास्ट हिस्टोपैथोलॉजी इन ऑस्टियोमा. Now coming to prognosis and follow-up, they do not recur. Osteomas generally do not reoccur, and osteoma as a single entity in jaw is very rare. It is mainly associated with Gardner syndrome with other entities. Now, goal of follow-up is to look for new osteomas or other signs indicative of Gardner syndrome. What I have told. Whenever we do follow-up, we should look for new osteoma, क्योंकि जो Gardner syndrome होते हैं उसमें more than one osteoma होते हैं. In fact, more than 3 osteomas. So we should look for more than one osteomas or new osteomas and which are indicative of Gardner syndrome. Okay, that's all for today's class. We'll be starting Gardner syndrome in the next class. Till then, like, share, subscribe and comment. Bye.